Professor Frank Lichtenberg from Columbia University, where we were just a couple of days ago to present on the impact of pharmaceutical innovation on cancer mortality in Spain, a bit of an oncology thread we have going on this morning. So over to you, Frank.
Thank you, Jerry. I know that this symposium is primarily about digital health, and it's about bioinnovation in general, and certainly digital health plays a very important role in that. However, there are some data challenges. I have, for the last several decades, been interested in trying to measure the impact of biomedical innovation on longevity, health, and medical expenditure. And I've done quite a few studies in many countries. And what I'd like to do in the few minutes I have with you is to tell you about a study that I recently performed about the impact of pharmaceutical innovation on cancer mortality in Spain during the period 1999 to 2016. And so I hope you can see my slides, and I'll begin with the observation that despite rising cancer incidence, cancer mortality has declined substantially in Spain during the 21st century. And let me show you a few graphs that illustrate that. This chart shows both the age-standardized cancer incidence rate, that's the blue line, and the age-standardized cancer mortality rate for males. And what you can see is that cancer incidence has been rising. The probability of being diagnosed with cancer has been going up, but the probability of dying from cancer has declined quite significantly since the early 1990s. That's for men. We get a similar picture for women. Cancer incidence is rising, but cancer mortality has declining. Now, that's one way of measuring cancer outcomes. Another one is to look at how many years of life have been lost due to cancer per 100,000 population, years lost before the age of 75. And we see that that has fallen quite dramatically by something like a third between 2000 and 2020. So there's been quite a dramatic decline in premature mortality from cancer. And another indicator that I think is interesting to look at is the average age at death from cancer. So if someone dies from cancer, according to the death certificate, how old were they? In 2000, the average age of death in Spain was 71. By 2020, it was over 74. So the average age of death climbed by more than 3 years. And we know that in general, that mean age of death is strongly correlated with life expectancy at birth. So cancer mortality has declined quite dramatically in Spain and other countries, but the magnitude of the decline has varied across cancer sites, across different types of cancer. And I can illustrate this by looking at the increase in the mean age at time of death between 1999 and 2016 for about, in this case, about 20 different types of cancer. And what we see is for several types of cancer, especially leukemia and lymphoma, the mean age at death increased by more than 6 years between 1999 and 2016. But for other types of cancer, the mean age at death has only increased by a year or so. And so the question is, why is that? Why do we see very different rates of progress for different types of cancer? And that's the question that I address in my article. And so I have a hypothesis about that. And my hypothesis is that pharmaceutical innovation, the authorization and use of new drugs for treating cancer, has accounted for a substantial part of the overall decline in cancer mortality and for the variation in decline across cancer sites. So that's the hypothesis that I examine in my study. In essence, what I do is I investigate whether the cancer sites, the parts of the body where people get cancer, for which there was more innovation, had larger reductions in mortality, controlling for the lag change in cancer incidence, the number of people diagnosed with cancer. And the measure of pharmaceutical innovation I use is the long run change in the mean vintage or year of initial authorization of the drugs for the treatment of a cancer. Let me illustrate how I measure that. And the way that I measure that, here are two data on two different types of cancer: bladder cancer on the left and rectal cancer on the right. And what I show here is a list of all of the drugs that have ever been approved in Spain that are used to treat these different types of cancer. And I'm going to look at the period. I have mortality data for the period 1999 to 2016. And if we look at all of the drugs for bladder cancer that had ever been approved by 1999, and we ask what's the mean year in which those drugs were approved, the answer is about 1978. So the average drug that had been approved by 1999 had been approved about 21 years earlier. And by 2016, some additional drugs had been approved. And so the change or the increase in the average number of drugs was about 5 years. So the drugs that were available in 2016, excuse me, were about 5 years newer than the drugs that had been available in 1999. That's for bladder cancer. But when we do the same exercise for rectal cancer, we see that the mean vintage of drugs increased by about twice as much. There was about a 10-year increase in the mean vintage of drugs for treating rectal cancer between 1999 and 2016. So I hypothesized that because, according to this measure, there was more innovation for rectal cancer than there was for bladder cancer, I would hypothesize that we should see a greater reduction in mortality, a greater increase in mean age of death for rectal cancer than we would for bladder cancer. Now, these are just two types of cancer. I have data on over 50 types of cancer. And so when we look across cancer sites at the change over this period in the mean vintage of the drugs that had ever been approved in Spain for treating that type of cancer, once again, we see that for a few types of cancer, there were large increases of like 10 years, but for others, the increase in vintage was only half as much. So that's the variation that I analyze. So the research design of my study is to look at the impact of pharmaceutical innovation as measured by the change in the mean vintage of drugs for a type of cancer that had been authorized. And I want to look at the impact of that on mortality, measured in a number of different ways: the average age of death, the number of deaths, and the number of years of potential life lost before several different ages. I control for the incidence of that type of cancer, that is the number of people that had been diagnosed with that type of cancer 6 years earlier, and the average age at the time of diagnosis. And so that's sort of the main research design. I use data from a number of sources, including the regulatory agency in Spain, the World Health Organization, and other reliable data sources. And so here, in a nutshell, this chart shows one of the main results of my study. What it shows is the correlation across cancer sites between the increase in drug vintage, that's measured along the horizontal axis, and the increase in the mean age at death over this 17-year period. And the size of these bubbles, so each bubble represents a different type of cancer. The area of the bubble, it represents the relative importance, the relative number of deaths for that type of cancer. And what we see is that in general, there's a strong positive correlation. That is, the types of cancer where there was the largest increase in the mean vintage of the drugs, like non-Hodgkin lymphoma, multiple myeloma, and leukemia, we saw much larger increases in mean age at death than we did for the cancers where there was a relatively small increase in mean vintage. And I am controlling for the change in incidence and the mean age at time of diagnosis, which is an indicator perhaps of cancer screening. And so this is this is one of the key results, and it's echoed in other results in the study. So when we take these results and say, well, how much did cancer mortality change during this period, and how much would it have changed in the absence of pharmaceutical innovation? So I can compare the actual increase in cancer mortality to the counterfactual increase in the absence of previous pharmaceutical innovation. And what the chart A shows is, as I said before, the mean age at death increased by about 3 or 4 years. But according to my estimates, if there had been no innovation, the mean age at death would barely have increased at all. So that almost in the entire increase in mean age at death is explained by previous pharmaceutical innovation. Now, innovation or the change in vintage also explains a significant part. It explains variation in the number of deaths. So the number of cancer deaths increased by 144,000, partly because of the aging of the population. My estimates imply that, I'm sorry, the actual number of deaths increased by 102,000. But my estimates imply that in the absence of innovation, the number of deaths would have increased by 144,000. And similarly, I can calculate both the actual change in the number of years of life lost before ages 65, 75, and 85, and the counterfactual, that is how much mortality would have increased if there had been no previous innovation, and therefore if vintage had not increased. So those are some of the key estimates that I obtained from my study. I also do things a slightly different way. Instead of looking at the change in the vintage of drugs, I look at the change in the number of drugs. And that also predicts mortality, but not quite as well as the change in vintage. So perhaps you're not shocked by the fact that the cancers where there's been more innovation, we've seen greater reduction in mortality, that these drugs have been clinically effective. But we also want to know, are they cost effective? That is, yes, we can extend the lives of cancer patients by developing new treatments, but those treatments cost money, in some cases a lot of money. And the question is, what's the bang per buck, or the bucks per bang, the cost per life year gain? And how, there is a certain standard that's often used for determining cost effectiveness. And according to one study by the World Health Organization, interventions that avert one disability adjusted life year for less than average per capita income for a given country are very cost effective. And Spain's per capita income in 2016 was about 24,000 euros. Well, I can do a back of the envelope calculation of what the cost per life year, although not a quality adjusted life year, are from these new drugs. The data from IQVIA indicate that about $1 billion was spent in Spain on new cancer drugs, that is post 1999 cancer drugs in 2016. And so if we take that figure and divide it by the number of life years before age 75 gained, that implies that the cost per life year gained was only about 3,000 euros. And that's only about 14% of Spain's per capita GDP, which implies that those drugs were highly cost effective overall. Of course, that's an average across the entire set of drugs. Some drugs were more cost effective, others less cost effective. That's the average figure. So I do have a working paper, which is currently under review at a peer-reviewed journal, and I'd be glad to share that with anyone who reaches out to me.